Welcome to the Medicaid 101 training series developed in partnership between MassHealth and the University of Massachusetts Medical School. Today's training is Module 8 in the series and is intended for local education agency direct service providers. This training was distributed in April of 2021 and was accurate at the time of distribution. As always, local education agencies are responsible for reviewing information on the school-based Medicaid program website, which can be found at mass.gov/masshealth/schools to determine whether any subsequent guidance has superseded content shared here. MassHealth does plan to update these trainings periodically as needed. The Medicaid 101 training series is designed to provide the essentials to understanding the school-based Medicaid program, referred to as SBMP. Some modules are designed for a broad general audience. Other modules are targeted to the learning needs of a specific audience within each local education agency or LEA. I'm not going to read these all out, as I'm sure that everyone in attendance today most likely is aware of the series, but the modules are shown here for your reference, and we encourage you to access any of the other modules in the series that might be helpful and appropriate for you and your responsibilities regarding the Medicaid program for your school district. And these are the additional modules in the series. So here's today's training agenda. Please note this module does assume that you've already reviewed the introductory module in the Medicaid 101 series. Therefore, the agenda for this training builds upon that background knowledge. So we will discuss the training objectives and review what is the direct service claiming or DSC portion of the program. We'll cover the reimbursable services requirements, review interim claims and billing forms. We'll discuss the role of ICD diagnosis and/or signs and symptoms codes, and go over some random moment time study tips for direct service practitioners. So we hope that by the conclusion of the training, you will develop an understanding of what direct service claiming is and what types of services are reimbursable, and understand your role from Medicaid's perspective as a clinically trained healthcare professional who is working in a school setting. Understand Medicaid's requirements that have to be met for services you provide to be considered reimbursable services, and gain a better understanding of how your direct service work activities should be documented if you're selected to respond in the random moment time study. And again, the note, just this is introductory 101 level. Every little detail you need to know is not going to be included here, but we really hope that this is a great place to start foundational knowledge. There is a lot here, but not everything. So we will provide some additional training opportunities and resources towards the end of the presentation. And there is an entire direct service program guide available on the SBMP website as well. So let's begin with what is direct service claiming. This is a program that LEAs can use to seek federal reimbursement for the costs that your LEA, your school district, is incurring for providing direct services. The SBMP, the school-based Medicaid program, covers direct medical services provided in the school setting, including things like speech, occupational, and physical therapy, psychological counseling, skilled nursing services, audiology services, personal care services, and applied behavior analysis therapy services when the Medicaid claiming requirements are met. The SBMP program provides reimbursement for the provision of these Medicaid covered services when they meet Medicaid's definition of medical necessity and all other program requirements, whether they're provided pursuant to a student's IEP or not. LEAs, which is the local education agency or school districts, submit interim claims for covered services provided to eligible MassHealth enrolled students through MassHealth's MMIS. That's their claiming system. So every time a service is provided to a MassHealth enrolled student, that's one of the reimbursable services, a claim is submitted. Providers must submit these per unit or interim claims for all services that you're seeking reimbursement for when the ultimate reimbursement actually comes through the direct service cost report. So you file interim claims and then report your costs at the end of the year in a cost report. So what are the Medicaid covered direct services? The services listed below are the Mass Health covered services. So these are things that are Mass Health benefits to students enrolled in the Mass Health program. So it's, again, the ABA, audiology, dental assessments or screenings, medical nutritional services, the mandated health and behavioral health screenings, OT, PT, speech therapy, psychological counseling, personal care, skilled nursing, and some vision services. The full list of covered services and qualified practitioners is posted on the school-based Medicaid website. That's the link if you want to go there following the presentation or any other time. So an important concept is, how do we take something that's a covered service and make it reimbursable in this program? There are requirements that have to be met when a covered service is delivered, which make that service eligible for reimbursement or make it a reimbursable service. The requirements are that the practitioner who provided the service must participate in the random moment time study in the appropriate direct service pool if the services are being provided in district. Practitioners providing services to students out of district, such as in one of the special education private schools or in an educational collaborative program, are exempt from the RMTS. However, all of the remaining requirements for reimbursement still apply to out-of-district services. The practitioner also has licensure qualifications that they need to meet for the type of service that they're providing, and the services need to meet Medicaid's definition of medical necessity. We're going to talk about all of these things in this training. The service has been authorized by a qualified practitioner, and the service has appropriate documentation. LEAs must ensure that each of these 5 requirements is met before submitting an interim claim for the service that was provided. So what does this look like in school-based practice? A large portion of the Medicaid covered services provided in the school setting are provided pursuant to a student's IEP. IEP-related services, such as PTOT, speech therapy, ABA therapy, behavioral health counseling, are common examples of services that can be reimbursable when the Medicaid program requirements are met. Additionally, some students receive Medicaid covered services that have nothing to do with special education or an IEP. For example, healthcare services such as nursing care or behavioral health counseling and others are often provided due to a student's medical or behavioral health needs that has nothing to do with special education. And many students receive the health screenings that occur in schools, such as the vision screening, the hearing screening, and others. All of these services are things that Medicaid covers and can be reimbursable when the reimbursement requirements are met. So we're going to talk about the process for Medicaid qualified service delivery. We're basically going to look at the service delivery process or cycle for IEP services first, since that's the largest portion of services being delivered and reimbursed through the school-based Medicaid program. And we're going to use this as a framework to compare the IEP process, the work performed by an IEP team, and draw a parallel to the Medicaid qualified services process performed by a qualified practitioner, who typically would be part of the IEP team in the case of IEP services. And we're trying to illustrate that the IEP process is not the same thing as the Medicaid qualified service process, and it doesn't substitute for it, but they actually work nicely in parallel. It's actually pretty cohesive. So we're hoping that this is a helpful framework to understand how school-based practice fits with the way Medicaid looks at the world. So healthcare services provided in a school setting. As a related services provider, you are a clinically licensed healthcare professional working in a school setting, and you bring your clinical expertise to the rest of your school's educational team, and you all work together to support the needs of your students. Your school district hired you to perform your job because you have clinical skills and training that allow you to provide healthcare services that cannot be safely or effectively provided by other types of school staff. So it's really important to understand that educational needs and healthcare needs absolutely can and do overlap. Medically necessary healthcare services have a clinical basis, but they also may help a student to achieve educational goals and access the curriculum. From Mass Health's perspective, it's your role in the IEP process as the qualified practitioner that Mass Health is focused on. So let's compare the special education process to the Medicaid qualified services process. We're trying to draw a parallel to see that they're quite similar and how they really neatly fit together, but it's not exactly the same thing. They work in parallel. So for example, I'm sure everyone is very familiar with the IEP process. Somehow or some way, a student might be referred or identified as needing to be evaluated for special education. So there's an evaluation, there's a determination of eligibility, an IEP is written, there's a placement of a student who needs related services with a practitioner who's going to provide them, instruction occurs, and then there's an annual review process, and so forth. And you have an IEP cycle that's happening. With Medicaid qualified services, it's really very, very parallel. So initially, you might be aware of that the student needs to be looked at by a clinical professional from a variety of ways, again, referral or identification methods to identify you've got a kid that you need to take a look at. But a clinical evaluation by a qualified practitioner is going to be performed, and they'll determine whether the student needs services. They're going to write a plan of care to provide those services and assign this student to a practitioner's caseload to receive the services. Then the therapeutic interventions or services are provided, and at some point the student will be reassessed and they'll determine the need for continuing services or alteration of services and so forth. So it's very much a similar cycle. All of these steps in the cycle could completely be performed by the same practitioner or different practitioners. It doesn't matter. So to qualify for Medicaid reimbursement, services have to be provided by qualified practitioners who have a clinical license where required under state law and are providing services within their scope of practice as that licensed clinician. The list of qualified practitioners, again, it's that same document, LEA Covered Services and Qualified Practitioners document. It's at this link up on the school-based Medicaid website, and it lists all of the different licenses Medicaid is looking for. Please note that although school-based Medicaid program practitioners may also hold licenses through Department of Elementary and Secondary Education, for the purposes of the SBMP, licensure status is based on the Massachusetts Clinical Licensing Boards. The exception to that is the Department of Ed, the DESE licensed psychologists who are explicitly listed as qualified practitioners for the school-based program, and you'll find them listed in that qualified practitioners document. LEAs do need to monitor the license status of staff and make sure that only appropriately and actively licensed staff are submitting interim claims or having claims submitted on their behalf and are included in one of the time study direct service practitioner pools. So the complete list, again, it's that document on the website, but just we tried to create a little one-page summary to simplify here. So the types of practitioners and the body, the licensing body that Medicaid is looking to for the license that makes you a Medicaid qualified practitioner are listed here. So let's review some practitioner qualifications, starting with clinical supervision. So Medicaid qualified providers do need to follow their individual licensing regulations regarding any supervision requirements. Supervision may be provided indirectly or telephonically, something like that, if your licensing regulations allow that, and the supervisor needs to document supervision according to your license regulations. Licensed practitioners whose licensing regulations require that they be supervised are not considered Medicaid qualified unless that clinical supervision is in place and is being documented. So for example, an adjustment counselor who is also a licensed certified social worker, an LCSW, requires clinical supervision per the regulations of the Massachusetts Board of Registration of Social Workers. Services provided by an LCSW who is not being clinically supervised don't meet Medicaid qualifications to be billable under Medicaid. It's important to note that direct supervision is not a substitute for licensure for all service types except personal care services and ABA therapy provided by an autism specialist. If the LEA staff does not hold a current and active license for the practice specialty area for the services that are being performed, then the staff does not meet Medicaid requirements for reimbursement, even if they're supervised by a licensed practitioner. So, for example, a paraprofessional carrying out activities recommended by a licensed occupational therapist would not be reimbursable. The only reimbursable providers for occupational therapy services would be a licensed occupational therapist or a licensed occupational therapy assistant. Evaluations. So, regardless of referral source or how it was that it came to be that you identified that a student needs to be evaluated, both the IEP process and the Medicaid qualified services process start with an evaluation by a qualified practitioner. So in the IEP process, there might be several IEP team members who have a role in evaluating a student's needs for various types of services that might encompass educational services, social services, and health-related services and supports. In the Medicaid process, we're looking at a clinical evaluation, which for Medicaid's purposes, we're looking at the evaluation for healthcare services that's performed by a Medicaid qualified practitioner whose scope of their license allows them to determine a student's needs for that type of healthcare service. The extent and type of an evaluation needed is consistent with clinical standards of practice that's set by the licensing board. All covered services must meet medical necessity standards. There's a state regulation, if you're interested in it, that goes into, in regulatory terms, medical necessity standards. So what does this look like? In the IEP process, again, an IEP team comes together and determines whether a student qualifies for special education and makes the determination about that student's IEP. In Medicaid's view of what's happening, there's a determination by a qualified practitioner through their evaluation process who's determining whether it's medically necessary to provide healthcare services to the student. That signed evaluation report substantiates the medical need that a qualified practitioner determined that there's medical need, not the IEP. All covered services must meet medical necessity standards to be reimbursable. And of course, MassHealth does not pay for services that aren't medically necessary. So that means that the service must be reasonably calculated to prevent, diagnose, or prevent the worsening of, alleviate, correct conditions in the student that endanger life, cause suffering or pain, cause physical deformity or malfunction, threaten to cause or to aggravate a handicap, result in illness or infirmity. If the service does not meet this standard, it's not reimbursable. So all of that means there's an underlying cause. It could be physical health cause. It could be a mental behavioral health cause. There's an underlying issue and a skilled intervention is required to address that underlying issue. Services that are required under a student's IEP or health plan or provided at the request of a third party aren't automatically considered medically necessary. Just because something's in an IEP or just because something's requested doesn't make it medically necessary, right? Let's talk about skilled services. This is so important, I think. To be a Medicaid reimbursable service, the service must be skilled. So that means it requires the clinical expertise of the licensed practitioner. If the student themselves or an untrained layperson could provide the care, then it doesn't meet the Medicaid medical necessity standard because it's not a skilled service if an unskilled person can do it. The only exception to this requirement is personal care services, which are routinely provided by paraprofessionals and by definition do not require clinical skills to provide them. The professionally recognized standards requirement, this says that medically necessary services must be of a quality that meets professionally recognized standards of healthcare and must be substantiated by records that evidence that the medical necessity and quality was there. This means that the amount, frequency, and duration of services that are provided would be considered reasonable by professionally recognized standards of practice for the clinical service specialty, and they require the skill level of the qualified practitioner to provide them. Practitioners are responsible for understanding their own standards of care and scope of license, including whether the clinical standards of practice differ from educational standards of practice. For services to be within the scope of a practitioner's license, the student's condition must require treatment of a level of complexity and sophistication that can be safely and effectively performed only by such a licensed practitioner. In other words, only someone qualified with the appropriate skills and training can effectively address the issue. ICD diagnosis and/or signs and symptoms codes. So the clinical evaluation performed by a qualified practitioner is often the first source of identifying the reason that a healthcare service is medically necessary. The reason needs to be translated for claiming purposes into a clinically appropriate ICD code. Per HIPAA requirements, every claim has to include a clinically appropriate ICD code that's supported by the clinical documentation, and all it does is explain why the child needs the service. The LEA may opt to utilize an ICD code that relates to the presenting signs and symptoms instead of, or maybe in addition to, a formal diagnosis. Every interim claim includes at least one ICD code, and someone at the school is responsible for ensuring that there's at least one clinically appropriate ICD code that explains why the service was necessary on each claim. When appropriate, an ICD code that is provided by a qualified practitioner that's not employed or contracted with the LEA, such as if you get an order from a physician or nurse practitioner outside of the school, if they identify a ICD code, you can report that on a claim. You just need to maintain written and signed documentation of where that diagnosis came from. So let's talk about the plan of care and how that relates to Medicaid service authorization. So in the Medicaid program, qualified services have to be authorized by a qualified practitioner through a written plan of care or treatment plan or order. They can be called a number of things. So if we're again trying to look as a parallel to help provide a framework in the IEP process, the IEP team documents the student's disability and identifies the comprehensive program of services and supports that the school is going to provide to address the student's needs so the student can succeed in school. For Medicaid purposes, as part of that IEP team, there's a qualified practitioner who, following an evaluation or assessment of the student's healthcare needs, writes a plan of care and defines the course of skilled treatments or interventions that the child needs to achieve a specific clinical treatment goal or goals. The clinician-signed plan of care authorized services pursuant to that plan. So service authorization or plan of care must be written documentation signed by an appropriately licensed and qualified practitioner that documents the medical necessity of the service and the plan of care. A signature on a plan of care can never be backdated, and any services provided prior to the signature date of a plan of care are not authorized and not billable. Determination of medical necessity and the development of a clinically appropriate plan of care typically are going to occur following an evaluation or some form of appropriate clinical assessment, and the extent and type of assessment needed to support that medical necessity and to develop or revise a plan of care just needs to be consistent with clinical standards of practice. That's really saying it needs to fit what the student needs and what the treatment is so far and the student's needs and standards of clinical practice. Service authorization requirements are consistent with clinical standards and requirements of each practitioner's licensing bodies. The licensing bodies and standards of practice for most SBMP covered services require a plan of care. The plan of care should be developed consistent with those standards of practice, including ensuring that the license requirements for the person who develops the plan of care and the frequency under which that plan of care might be revised and so forth are just consistent with the standards of practice of the license. So as with all documentation, the plan of care, which is authorizing services, must directly include all of this information or incorporate supplemental information by reference. So the name of the student who the services are going to be provided to, the student diagnosis or presenting signs and symptoms, and or a relevant ICD code, The services that are being authorized, this would be the description of services to be provided, and it should be written at an appropriate level of detail, again, according to clinical standards of practice of what level of detail is necessary to make the plan, the treatment plan, clear. The complete date that the plan of care was written and signed, the frequency of services would be in a plan, the duration of services if appropriate, and then a clinical rationale or justification for why the services are necessary. This, again, you should be writing this at an appropriate level of detail, following clinical standards of practice for your clinical discipline area. The plan of care is going to indicate the time period for which these services are being authorized. The printed name, legible signature, signature date of the licensed practitioner who is writing the plan of care within his or her scope of license, including the type of license held, a license number, and again, the note, you can never backdate a signature. And then the authorizing practitioner's contact information should be on the plan. The plan of care which authorizes services must directly include information or incorporate supplemental information by reference. So I just wanted to go over that just a little bit more because that sometimes causes some confusion. So information that must be directly in the plan of care is any information identifying the student, the description of services being authorized, including frequency, duration, time period for the services being authorized, and the authorizing practitioner's information, everything about them, including the practitioner's signature and signature date. That must be in the plan of care. Supplemental information that could potentially, if it was appropriate, be incorporated by reference might be the clinical rationale or basis for medical necessity. That might come from somewhere else, such as an evaluation, student diagnosis, or presenting signs and symptoms, and or the ICD code. Again, that information might be contained in an evaluation report, which could be referenced by the plan of care. You'd want to include the name of the evaluator, the date of the evaluation. That information might be contained in documentation that came in from a community provider, which again, you could reference in the plan of care, including the provider's name and the date of the provider's order or whatever the document is. As we mentioned at the beginning of the presentation, the SBMP does provide reimbursement for healthcare services that are completely unrelated to special education and not pursuant to an IEP. The requirements for reimbursement of IEP services and non-IEP services are the same. There are a few situations that occur when you're not talking about IEPs that will need to meet the service authorization requirement in a slightly different way than with normal IEP services. So the examples here, unplanned services, screenings, and evaluations are categories of services that aren't going to be resulting from an evaluation, writing a plan of care, and delivering services. So when unplanned nursing services are provided pursuant to a physician's standing order rather than a plan of care, the standing order may serve as the authorization. Unplanned behavioral health interventions can't really be pursuant necessarily to a plan of care because they were unplanned, but medical necessity should be supported through service documentation, and the service is considered authorized when the documentation signed by a qualified practitioner is indicating that the service was necessary. The EPSDT screenings that are listed in the school-based Medicaid program billable procedure codes document are considered automatically because they're necessary health screenings considered to be authorized. So no additional authorization is required for those. And since evaluations are performed to determine whether services are necessary, the evaluations themselves don't require a separate authorization. The documentation of the evaluation would support that it was medically necessary to evaluate and would include a description of the clinical reasons that it was appropriate to and necessary to evaluate the child. So let's talk about service delivery documentation. All Medicaid qualified services must be documented. So in terms of instruction, IEP services are provided to students to address the educational goals that are in the student's IEP. Therapeutic intervention for Medicaid purposes is the qualified practitioner documenting the specific skilled treatments or interventions they provided to the student during each service session. So these signed clinical treatment notes document that the treatment provided was consistent with the plan of care and was working toward achieving specific clinical treatment goals. Service documentation substantiates that the previously described requirements for reimbursement were met. So LEAs are responsible for ensuring that practitioners complete sufficient clinical documentation for any covered services provided to students if you're seeking reimbursement for that service. Documentation can be completed using a paper form, a chart, medical record, an electronic health record, whatever you choose, as long as requirements for clinical documentation and your practitioner's signature or electronic signature requirements are met. And Mass Health doesn't endorse any particular clinical documentation form or process or system. You don't want Mass Health to dictate that. That is for you to decide what works at your LEA and should meet your clinical standards of practice for clinical documentation. Just a note that service documentation is not the interim claim record and it's not a billing form. We're going to talk about that a little bit later. So service documentation, again, can be in the format of your school district's choosing, but at a minimum, these are data elements that should be directly in the documentation. Multiple services delivered by the same practitioner to the same student could be documented in a single form if that's what you use. But you're going to include the student's name, date of birth, Mass Health ID number if known, some other student ID number or the SACID, school district name, school name if different, the date of service or services, the time and duration of services, an indication whether it was an individually delivered service or in a group setting, an indication whether it was pursuant to an IEP or not, the diagnosis or presenting signs and symptoms information that translates to a relevant ICD code, information that indicates if it was telehealth, if it was provided virtually, that needs to be indicated, and an activity or procedure note. The activity or procedure note should be written at a clinically appropriate level of detail, again, following the clinical standards of practice for the clinical discipline that's involved. Printed name, legible signature, signature date of the practitioner. We need a legible printed name and signature of a supervising provider if it was applicable, and the practitioner's type of license and license number. For more details on service documentation, the Direct Service Program Guide that is up on the Resource Center provides more details. Reassessment. So in the IEP process, there's an annual review of the various components of an IEP and an opportunity to make changes to the IEP as needed. For the SBMP, reassessment for the purpose of determining whether changes are needed to a plan of care occur at clinically appropriate intervals. So again, trying to parallel the two in the annual review process, in the IEP process, there might be several IEP team members who have a role in reviewing the student's progress towards achieving their IEP goals and continuing needs for the various types of services that they're receiving pursuant to that IEP. We're talking about the healthcare services. So for Medicaid's purpose, the reassessment is what Medicaid's looking at, and the interval between assessments or reassessments and potential revisions to the plan of care are going to be determined by the needs of the individual student and the clinical standards of practice for the type of service. The extent and type of assessment needed to support medical necessity or to revise a plan of care, again, should be consistent with your clinical standards of practice and what the student needs. Interim claiming is required. Whenever an LEA provides a reimbursable service for which the LEA seeks reimbursement to an eligible Mass Health enrolled student, an interim claim must be submitted. Every time a qualified practitioner who participates in a direct service RMTS pool provides a Mass Health covered service with the required authorization and service documentation that meet Medicaid's definition of medical necessity, in other words, is a reimbursable service to a Mass Health enrolled student, an interim claim must be submitted. A note on billing forms. So LEAs can choose to utilize a billing form or system for the purpose of facilitating that interim claiming. Examples include things like electronic billing systems purchased directly from a software company or through a billing vendor, or an LEA or vendor developed paper form, perhaps. This is typically separate from service documentation that we've been talking about throughout this training module. And how this is implemented in each LEA is going to vary. So your LEA may utilize a system or software that fully integrates clinical documentation with the Medicaid billing process, or this documentation and information may stand alone. Your LEA's process might be paper-based, computer-based, a little bit of both. As a participating direct service practitioner, it's your responsibility to seek guidance from your clinical leadership or your Medicaid coordinator at your school district regarding your LEA's internal procedures for meeting all of the Medicaid program requirements. There is a billing form specific for out-of-district services. So practitioners who work in a private special education school or collaborative program, Department of Elementary and Secondary Education, DESE has developed a billing documentation form specifically for students in the out-of-district placements, and the form is available on DESE's website. That's the link to where the form is located on DESE's site. It was fairly recently updated in May of 2019. As described in this advisory, the form is mandated. Out-of-district programs and public schools should only be using a different format for submitting information if it's mutually agreed upon between the school district that sent the child or placed the child and the private school, and contains all of the required data elements. A little note on procedure codes and service units. So depending on the billing forms and processes in place in your LEA, practitioners may need to indicate which procedure code should be billed for services performed. The school-based Medicaid program uses a limited set of procedure codes for interim billing purposes. So there's a complete list, again, on the website if you want to see the complete list. For Medicaid billing purposes, each service must be billed in units, which in most cases translates to service duration. But in other cases, some of the services are billed sort of per encounter or per visit. So for example, individual speech therapy is billed with the CPT code 92507, and it's billed in increments of 15-minute units. A vision screening is billed with 99173, and it's just billed per screening. It's always billed as one unit. Doesn't matter how long it takes to complete the screening. So we recommend that everyone refer to any specific instructions at your LEA about the billing forms or electronic or paper, whatever they may be, that are in process and in use at your LEA. We do often get the question of what exactly is on the interim claim that's submitted to MMIS, submitted to the Medicaid claim processing system. So the information on an SBMP interim claim record is who received the service, which is identifying the Medicaid enrolled student by name, date of birth, their Medicaid ID number. Who provided the service is identifying the LEA or school district submitting the claim. When was the service provided? That's the data service. What service was provided? That's identified by the procedure code and modifier. The modifier indicates whether it's pursuant to an IEP or not, or provided in district or out of district. How many services were provided? That's that units. Sometimes that's a time indication. It might just be per encounter. Why was the service provided? That's the ICD code that tells you why the service was necessary. Where the service was provided, there's a place of service code on the claims. It either indicates in school or remotely via telehealth, and the amount of payment that the LEA is requesting for the service. So just a really important note that most of the documentation that we've talked about throughout this presentation is retained by the LEA to support the claim in case of audit. Most of that never actually goes to MassHealth. And then just to wrap us out, the random moment time study. As a direct service practitioner, you're going to apply your understanding of reimbursable service requirements when you answer a random moment if selected. So if you happen to be providing a direct healthcare service or preparing to provide a direct healthcare service or documenting that you provided a healthcare service at the time of a randomly assigned moment, you're going to have to answer questions that say, was it medically necessary? Was it authorized? Was it within your scope of clinical practice? And we're always going to ask whether it was pursuant to an IEP or not. You will never be asked to identify any student specifically, and you'll never need to know whether the student that you were working with was actually enrolled in Mass Health or not. That doesn't matter when you're responding to a random moment. LEAs, school districts also receive reimbursement for Medicaid administrative work activities performed by a variety of LEA staff, including the direct service practitioners. So if anyone is interested in learning more about the Medicaid administrative portion of the school-based Medicaid program and how that works in the random moment time study, there's a module posted online. Module 9 focuses on the administrative activities reimbursement part of the program. So again, just the refresher of these are the modules in the series, and some of these may be of interest to you for further information. And of course, contact information and resources, that mass.gov/masshealth/schools. That is the school-based Medicaid program website where all the official guidance and all kinds of information that we've referred to today is posted online. Some of the specific items we've talked about that are there: the direct service claiming guide, the covered services and qualified practitioners document, and the list of the procedure codes and fees, interim rates for those codes. As always, if you have questions or need assistance, the UMass Medical School School-Based Program Help Desk is available for you at schoolbasedclaiming@umassmed.edu. And there's our 800 number. We're here Monday through Friday from 7:30 to 7:30 to help you answer your questions, etc. So don't ever hesitate to reach out to us. And thank you so much for attending today. We all appreciate everything you're doing to try to understand this program and make this all work. And we're trying to help and support you in that way. So let us know what we can do to help and support you in any way that we can. Thank you so much.